This presentation was developed by our newborn intensive care pharmacist, Danielle Scott, at Intermountain Medical Center, along with me. We hope that this presentation will provide you with an overview of how this care process model should be utilized to manage our infants undergoing neonatal abstinence. The objectives of this presentation are the following. Number one, to define the prevalence of neonatal abstinence syndrome, or NAS. Number two, describe the basic pathophysiology of this disease. Number three, to recognize the clinical manifestations that are seen in infants with NAS. Number four, how to utilize the new Neonatal Withdrawal Index, or NWI, scoring tool. Number five, to understand the treatment algorithms and to construct appropriate recommendations of all pharmacologic options that are available to treat NAS. According to a national survey conducted by Patrick et al. In 2012, maternal opiate use from the years 2000 to 2009 has increased from 1.19 to 5.63 per 1,000 hospital births per year. This translates to a five-fold increase in maternal opiate use. As a result, neonatal abstinence syndrome has increased from 1.2 to 3.39 per 1,000 hospital births per year, translating to a threefold increase in NAS. To put it simply, one baby is born every hour in the United States who suffers from NAS due to in utero opioid exposure. Within this study period, 42 to 94% of infants required hospitalization for pharmacotherapy of NAS. Locally, in our state of Utah, between 2009 to 2012, 1,476 Utah mothers, equating to approximately 369 mothers per year, were reported to have used illicit drugs. As a result, 29.5% of the babies born to these mothers tested positive for illicit drugs at birth, equating to about 109 babies per year. Utah has seen a steady increase in the number of hospital discharges as a result of complicated pregnancies or births due to a mother's drug dependence between 2002 and 2011. Here is the graphical representation of the number of hospital discharges as a result of complicated pregnancies or births due to a mother's drug dependence in the years 2002 to 2011. Over the past decade, the number of Utah newborns diagnosed with NAS has increased 243%. This corresponds to a five-fold increase in charges for the treatment of NAS, even accounting for inflation. Whether an infant exhibits clinical manifestation for withdrawal depends on multiple factors, which makes it very difficult to predict accurately the timing, the severity, or the duration of withdrawal for each infant. There are maternal exposures, maternal factors, placental opioid metabolism, the mother or fetus genetics, infant factors, and environmental factors that all govern the clinical manifestation. Once withdrawal sets in, these are the common clinical manifestations. They can be broadly broken down into neurologic, gastrointestinal, or autonomic dysfunction. Within neurologic dysfunction, these infants can present with a high-pitched cry or irritability, sleep and wake disturbances, hyperactive primitive reflexes, hypertonicity, or tremors. Within the gastrointestinal dysfunction, they can present with feeding difficulties, vomiting, or watery stools. Lastly, the autonomic dysfunction can be manifested as sweating, sneezing, mottling, fever, nasal stuffiness, or yawning. Remember that this population of infants is at high risk for failure to thrive because of these dysfunctions. Other clinical manifestations may even include seizures, which reportedly has occurred in 2 to 11% of infants. Abnormal EEG changes have been reported in more than 30% of neonates withdrawing from opioids. Small for gestational age, which is defined as less than the 10th percentile for weight, can also be seen. And lastly, respiratory distress. Even though, as previously mentioned, the timing of withdrawal can vary, a generalized rule of thumb for opioid withdrawal is that babies with in utero heroin exposure, they tend to show symptoms within 24 hours of birth due to its short-acting properties. Withdrawal symptoms, however, can be severe. Babies with in utero buprenorphine exposure, which is one of the prescribed medications used to treat chronic opioid dependence, they tend to exhibit NAS symptoms within 24 to 48 hours, with less of severity of symptoms compared to heroin. Lastly, in utero methadone exposure, babies tend to withdraw even later at 24 to 72 hours. According to the American Academy of Pediatrics, if more than 1 week has elapsed between the last maternal opiate use and the delivery of infant, the incidence of NAS substantially decreases. Testing for in utero drug exposure continues to evolve. Across Intermountain Healthcare and University of Utah Medical Center, we will be using umbilical cord as our tissue of choice for toxicology screening. Similar to meconium, this detects exposure from early second trimester onwards. When an infant is showing signs or symptoms of withdrawal, ask our obstetric colleagues to send the umbilical cord for screening. This is a test developed by ARUP Laboratories, which offer a drug detection panel by high-resolution time-of-flight mass spectrometry on umbilical cords. This is still a qualitative test, even though detection cutoff levels exist for each drug and its metabolite. This test detects 21 opioid metabolites, 10 stimulant metabolites, 24 sedative hypnotics metabolites, PCP, and marijuana. The test will be reported as either not detected or present for each metabolite. Unlike meconium, where confirmatory testing may be needed for certain drugs, cord testing is the final test. The turnaround time is 1 to 3 days and is performed every day within ARUP Laboratories. If the umbilical cord is unavailable, send meconium as usual. Many scoring tools have been developed over the years to obtain an objective assessment of withdrawal severity. Bear in mind that these tools were largely developed for full-term infants. Some experts will say that premature infants have incomplete neurological development and may present differently. Nonetheless, the gold standard scoring tool in the literature is the Finnegan Neonatal Abstinence Scoring System. This is a 31-item scoring system, which makes it difficult to use consistently. Dr. Finnegan subsequently adapted it and named it the Modified Finnegan System, incorporating only 19 items instead. There is also the Lipsitz Neonatal Drug Withdrawal Scoring System, which is an 11-item system with 4 items only listing as yes or no answers. This scale has been recommended by the American Academy of Pediatrics. However, it still provides certain subjective ratings. For this care process model, we will be adopting the Neonatal Withdrawal Inventory, or NWI, which also incorporates 11 items of assessment. The NWI was developed in 1998 and was shown to have a 93% inter-rater reliability compared to only 80% with the Finnegan scoring. It is broken down into a pre-stimulus observation, a stimulus observation, and a post-stimulus observation. The pre-stimulus observation is a 1-minute observation prior to touching the infant as the infant begins to stir. The scorer will record the respiratory rate and observe for any tremors when undisturbed. If tremors are present, the infant receives a score of 4. These scores are weighted based on severity of symptoms. During the stimulus observation, the infant is essentially receiving cares, which include diaper changes, comfort measures, feeding, and medication administration if appropriate. Again, the scores are weighted based on symptomatology. Lastly, a 1-minute observation is taken after cares and comfort measures have been provided, giving a post-stimulus observation score. Frequently, babies that obtain a score during the post-stimulus observation will rely on pharmacological treatment for their withdrawal. Nurses will report scores obtained between 5 to 7 to alert practitioners that babies are exhibiting signs of withdrawal that warrant non-pharmacologic interventions. Non-pharmacologic interventions are always our first line of therapy and include low lighting, reducing the ambient noise, C-shaped holds, side-lying position, gentle rocking, and sucking on a pacifier. This is the optimal time to involve parents in the care of these infants to begin education on how to soothe these irritable infants. If infants begin to score 8 or higher, this is the time for pharmacologic interventions. An important point to emphasize here is that babies who have a non-opioid exposure rarely require pharmacologic interventions. They may still withdraw, but non-pharmacologic maneuvers are usually sufficient. We will next go over the management of NAS algorithm for the pharmacologic interventions for babies with in utero opioid exposure. The major goal of management is to promote normal patterns of sleeping, feeding, and weight gain. As soon as an infant exhibits withdrawal symptoms, the NWI scoring begins. This is normally done every 3 to 4 hours based on feeding intervals. If the scores are less than or equal to 7, again, reinforce non-pharmacological maneuvers. If 2 consecutive scores are more than 8, or a baby has persistent vomiting or watery stools with any score, start oral morphine sulfate at level 1 dosing. I will show you the dosing charts in the next slide. Here is the intravenous dosing chart and will only be used if the infant is not eating due to persistent vomiting or other indications of needing to be NPO. Take note that the level 1 dosing begins at 0.05 milligrams per kilogram per dose. If an infant is needing IV morphine, which carries a higher chance of respiratory depression, consultation with the newborn ICU is recommended. For the majority of babies, the PO dosing chart is what you need. The level 1 dosing here begins at 0.075 milligrams per kilogram per dose, which is higher than the IV dosing. Therefore, make sure you are ordering the correct dose. Take the infant's birth weight, for example, 3,000 grams, and order dosing based on whichever level your infant is at. As you wean, the level number increases, and this corresponds roughly to a 10% decrease in morphine dose each time. Levels 1 to 9 are dosed every 3 to 4 hours based on feeding intervals. Once level 10 is reached, we start to lengthen the dosing interval, first to every 6 hours, then to every 8 hours at level 11, to every 12 hours at level 12, and to once-a-day dosing at level 13. Going back to our algorithm then, once level 1 morphine is started, if the infant continues to score above 8, you can give an additional level 1 dose. At this time, adjunctive therapy should also be considered, since morphine is insufficient. I will go over the adjunctive therapy later. If the infant does well on level 1, and there are 2 consecutive scores that are less than 7, infant can be weaned to level 2. However, if the infant has persistent vomiting or watery stools, morphine should not be weaned regardless of the score, because this infant will not tolerate feeding. If 2 consecutive scores become more than 8 again, you can return to the previous dosing level. As long as the infant has 2 consecutive scores that are less than 7 without GI symptoms, do not hesitate to wean to the next level. The primary purpose of having a weaning schedule is that if the infant qualifies for weaning, we need to wean such that we can decrease the length of hospitalization as much as possible, but doing it in a safe manner. To recap, always use the birth weight as your dosing weight, and do not weight adjust medications even if the infant is beyond the first week of life. Second, consider adjunctive therapy at any level when you are unable to wean. Adjunctive therapy should not be reserved solely to level 1 dosing. Third, if an infant is started on IV morphine, make sure you use the weight-appropriate dosing level to convert to the oral formulation when ready. For example, a 3-kilogram infant on level 4 IV morphine should be converted to level 4 PO morphine, which will be a higher dose. IV dose does not equate to the PO dose. Scoring and dosing must be done for a minimum of 24 hours when you reach levels 11 and 12 before weaning, and a minimum of 48 hours at level 13. The earliest discharge upon reaching level 13 is on the 3rd day. Keep track of infants' weight gain and sleep patterns to determine the optimum time of discharge. Always use your clinical judgment and keep the infant longer if there are concerns. To sum up our algorithm once more, always start with non-pharmacologic interventions first to treat NAS babies. Involve parents or other family members early to learn these interventions. Pharmacologic therapy is reserved to relieve moderate to severe NAS signs and to prevent complications such as fever, weight loss, and seizures. The major goals are to normalize feeding and sleeping patterns, to ensure appropriate weight gain, and to ensure appropriate follow-up plan, including the assessment of home environment if needed, maternal referral for pain management and/or psychiatric help. Remember to involve social work early and to ensure adequate pediatrician follow-up. Initiate pharmacologic treatment if 2 consecutive NWI scores are more than 8 or if vomiting or diarrhea are present with any score. Standardized dosing schedules are based on birth weight for the duration of therapy. Dosing is started at level 1. Scoring and dosing should be done consistent with the feeding schedule, typically occurring every 3 hours, with the maximum undisturbed time limited to 4 hours if the infant is sleeping, to minimize the need for catch-up dosing. If 2 consecutive NWI scores are less than 7, morphine dose should be weaned to the next level. If 2 consecutive NWI scores are more than 8, morphine dose should be increased back to the previous level. Do not wean if there is persistent watery diarrhea or vomiting is present, regardless of the score. Scoring and dosing is done every 3 to 4 hours from levels 1 to 9. Level 10 is dosed every 6 hours. Level 11 is dosed every 8 hours. Level 12 is dosed every 12 hours. And level 13 is dosed every 24 hours. Levels 11 and 12 must be maintained for 24 hours prior to additional weaning. And level 13 must be maintained for 48 hours prior to discharge. Always keep track of the infant's weight gain and sleep pattern to determine the optimal time of discharge. For patients who require adjunctive therapy in addition to morphine sulfate, the first decision step is to review the in utero exposures. Is this a predominant opioid exposure? If yes, we recommend using oral clonidine as the adjunctive therapy. Start at 1 microgram per kilogram per dose every 4 to 6 hours to be given with the morphine dose. This may be increased by 0.5 to 1 microgram per kilogram per day to a maximum of 12 micrograms per kilo per day, as this is the FDA-approved dose for infants. Depending on when clonidine is started, always use the weight as initiation for dose adjustments. Monitor for blood pressures and heart rates with each increase in dose. This is because clonidine is an alpha-2 adrenergic agonist, therefore can cause hypotension and bradycardia. Once morphine is weaned off, start to wean the clonidine by 0.5 to 1 micrograms per kilogram per day until discontinued. Again, always use the weight at initiation for dose decrease. Now this time you would want to watch for rebound hypertension and tachycardia. If these side effects occur, resume the previous dose for 24 hours and attempt to wean again. Since there are no published studies on the optimal outpatient weaning of clonidine, we are not to discharge infants home on clonidine at this time. If this is not a predominant opioid exposure, this group is likely to be infants who have been exposed to multiple drug classes, including the CNS stimulants such as methamphetamine and nicotine, and have significant CNS hyperirritability. Oral phenobarbital may be added. You can load with 10 to 20 milligrams per kilogram per dose, followed by a maintenance dose of 2 to 5 milligrams per kilo per day, given once a day or divided twice a day, to begin 24 hours after the loading dose. Serum phenobarbital levels are not monitored unless its use is for the management of seizures. Increases in dose are also not recommended as infants gain weight. Essentially, infants are allowed to outgrow their dose as symptoms wane. Therefore, infants can be discharged home on phenobarbital. Weaning will usually be achieved over the first 6 to 8 weeks of life. We recommend breast milk feeding for babies with NAS. The only absolute contraindication is HIV positivity. If breast milk is of limited supply, particularly for mothers on methadone or buprenorphine treatment, consider mixing the formula and breast milk together and dividing the breast milk evenly during the day's feeding to ensure that the infant receives some amount of breast milk each time. If there are questions on the safety of drugs that are transferred through the breast milk, the American Academy of Pediatrics clinical report on the transfer of drugs and therapeutics into human breast milk provides a good guidance. Additionally, LactMed, with the following link, provides up-to-date information on drug levels in human milk and in infant serum, the possible adverse effects on breastfeeding infants, the potential effects on lactation, and the recommendations for possible alternative drugs to consider. Common herbal products are also included. To end our presentation, we will now present a patient case to illustrate the use of this care process model. BH is a 3-day-old, former 39.2-week, 3,540-gram infant, presenting with increased jitteriness, irritability, and sneezing. His mother has a history of polysubstance abuse, including heroin, methadone, methamphetamine, and nicotine. An order to begin NAS scoring has been written, and the first 2 scores were 8 and 11. Which of the following should be started? A, morphine at 0.27 milligrams IV every 3 hours, which is 0.075 milligrams per kilogram per dose. Or B, morphine at 0.27 milligrams PO Q3 hours at 0.075 milligrams per kilogram per dose. Or C, clonidine at 3.5 micrograms PO every 4 hours at 1 microgram per kilogram per dose. Or D, load with phenobarbital 71 milligrams PO times 1 at 20 milligrams per kilogram per dose, then start 9 milligrams PO twice a day at 5 milligrams per kilogram per day. The correct answer is B. Morphine at 0.27 milligrams PO every 3 hours is the correct answer, because this baby is withdrawing at 3 days of age. Therefore, he is likely to be withdrawing from methadone. Babies with heroin and methamphetamine would have presented with withdrawal earlier. So noting the time of presentation is key here. BH's next two scores are 5 and 2, but he's still very irritable and crying a lot. How should his therapy be adjusted? A, his morphine should be changed to level 5 because his NAS scores are so low. B, clonidine 3.5 micrograms POQ 4 hours at 1 microgram per kilogram per dose should be started as adjunctive therapy because he is still crying. Or C, morphine should be weaned to 0.24 milligrams PO every 3 hours at 0.067 milligrams per kilogram per dose, and NAS scoring should continue. Or D, he should be scored one more time to make sure his NAS score stay below 8, and then his morphine should be weaned. The correct answer is C. Morphine should be weaned to 0.24 milligrams every 3 hours, and NAS scoring should continue. Over the next few days, BH continues to have consistent scores of more than 8 on level 2 of morphine. He is extremely irritable and sleeps only for a short time. What is the next step in treating BH's NAS? A, increase the morphine dose back to level 1 and start clonidine at 3.5 micrograms POQ 4 hours. Or B, increase the morphine dose back to level 1 and load with phenobarbital at 20 milligrams per kilo per dose, then start 9 milligrams PO twice a day at 5 milligrams per kilogram per day. Or C, stay at level 2 until the NAS scores are less than 8, then wean to level 3 even if he is still experiencing loose stools. Or D, increase the morphine dose until the NAS scores are less than 8 to a maximum dose of 0.15 milligrams per kilogram. The answer is B. Increasing the morphine back to level 1 and adding phenobarbital rather than clonidine as the adjunctive therapy is appropriate because the baby has exposure to 2 other CNS stimulants, which are nicotine and methamphetamine, and he is presenting with continued hyperirritability. Here is a list of references that users can refer to for the evidence-based approach that we have taken in the development of this care process model. Should questions arise as this care process model implements, feel free to contact the following staff members. Again, thank you for your attention and participation in the care of these infants and families.